Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession. I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I humbly urge you to sit back and spare me part of your very precious time to share with you some precious tips which may prove useful in your line of duty. So welcome to part 65 of our Pharmacotherapy MCQ series, which majors in Rheumatology. Question 1 reads, HPP, a 45-year-old patient, has been newly diagnosed with rheumatoid arthritis, which will from now on abbreviate as RA. The rheumatologist at your hospital is considering him a perfect candidate for methotrexate therapy. My question 2 is, which of the dosing schedules listed below would best suit the management of this diagnosis in the case of Mr. HPB? Would you settle for a once-a-day regimen, a once-a-week regimen, a twice-a-day regimen, or a once-a-month regimen? I'll give you 10 seconds to choose the correct answer. So I would opt to administer the methotrexate once a week. Now, in the context of management or treatment of rheumatoid arthritis, methotrexate is used or administered in doses of at least 5 milligrams, and it's administered once a week to the patients regardless of the route of administration, whether it's oral, sub-Q, or intramuscular. Now, methotrexate is a common initial therapy for the treatment of RA and is used in low doses compared to those used in oncology for cancer treatment. Now, the once weekly schedule is chosen to reduce hematologic, GI, and even hepatic side effects of methotrexate, just to reduce harm to the patient while still obtaining clinical effects. Let's move to the next question, please. And it reads, which of the statements listed below is or are true with regard to etanercept, which is marketed as Enbrel, for the treatment of psoriatic and rheumatoid arthritis? Is it true that it can worsen or exacerbate heart failure? Is it true that it can be administered at a frequency of once or twice a week? Is it true that it is approved to be administered by IM or IV injection? Or is it true that it selectively inhibits TNF? I'll give you 10 seconds to choose the correct answer. So answers A, B, and D are all correct. Now, etanercept, which is marketed as Enbrel, can only be administered subcutaneously. So administered SC and not IV, and that makes answer C wrong. The other answers are all true. Just like to remind you that Enbrel, etanercept, is an injectable biologic disease-modifying anti-rheumatic drug, which we abbreviate as DMARDs. D is a DMARD agent, that is a TNF antagonist, which can only be administered subcutaneously for the treatment of, for example, ankylosing spondylitis, psoriatic arthritis, and even rheumatoid arthritis. Now, I'd also like to just remind you, as a by the way, that Erelzi, E-R-E-L-Z-I, is a biosimilar of Enbrel. So in cases where you can't access Enbrel, you can still opt for Erelzi with good clinical outcomes. Let's move to the next slide, please. And the question reads, Mr. JMJ, a 57-year-old male patient, presents to your rheumatology clinic. He is known to suffer from chronic osteoarthritis, what we abbreviate as OA. He comes in with ongoing joint pain despite adequate trials of oral analgesics administered alongside intra-articular corticosteroid injections. Mr. JMJ can't afford surgery currently or any time in the near future. He consents to a test of intra-articular hyaluronic injections. So my question to you is, which of the joints listed below is the only appropriate one for this treatment? Would it be the shoulder, the elbow, the hip, or the knee? The knee would be the best choice. Now, the only joint approved for hyaluronic injections is the knee. I'd just like to remind you that hyaluronic products include Durolane, D-U-R-O-L-A-N-E, Euflexa, E-U-F-L-E-X-A, Genvisc, Hyalgan, Hymovisc, Monovisc, Synvisc, Trivisc, Visco 3. All these are FDA approved for intra-articular injections for osteoarthritis of the knee. Hyaluronic derivatives may also be injected intradermally for dermatosis, for facial wrinkles and folds. They can also be used in lip augmentation and hand augmentation by plastic surgeons, and they can even be used for skin ulcers and wounds. Those are just by the ways. Let's move to the next question, please. And it reads, which of the products listed below selectively inhibits interleukin-1, abbreviated as IL-1, receptors on target cells, resulting in a reduction in inflammation associated with RA? Is it adalimumab, marketed as Humira? Is it anakinra, marketed as Kineret? Is it leflunomide, marketed as Arava? Or is it sarilumab, marketed as Kevzara? I'll give you 10 seconds to choose the correct answer. So anakinra or Kineret it is. Now anakinra or Kineret is a DMARD that inhibits IL-1 receptors to reduce inflammation associated with RA. Now sarilumab or Kevzara is also a DMARD. It's a monoclonal antibody that inhibits interleukin-6, not 1. Interleukin-6 receptors to reduce inflammation associated with RA. Leflunomide or Arava is also a DMARD that inhibits pyrimidine synthesis, and that leads to antiproliferative effects of the immune system, and that reduces inflammation associated with RA. Adalimumab or Humira, on the other hand, is also a DMARD, but it's a monoclonal antibody that inhibits TNF-alpha receptors to reduce inflammation associated with RA. It is also used in the treatment of Crohn's disease, ulcerative colitis, plaque psoriasis, and even a disease which we call hidradenitis suppurativa. I would urge you to read further on that. Now, due to the large protein structures, biologic agents must be administered parenterally, since oral administration would expose them to gastric acid and damage the biologic drug molecule, rendering them pharmacologically inactive. They must be injected. They can't be taken in oral form. Let's move to the next question, please. And it reads, your clinical team is considering initiating febuxostat, marketed as Hyaluronic, in a patient known to suffer from gout. As the clinical pharmacist seconded to the rheumatology clinic, you review the patient's medications due to a known potentially life-threatening drug interaction leading to bone marrow suppression with febuxostat. So my question to you is, with which of the drugs listed below can febuxostat interact, leading to this severe adverse drug effects, that is bone marrow suppression? Would it be with carbamazepine, methotrexate, azathioprine, or ethambutol? I'll give you 10 seconds to choose the correct answer. So bone marrow suppression would occur if you co-administered febuxostat with azathioprine. Remember, febuxostat or Hyaluronic is a xanthine oxidase inhibitor used for the treatment of hyperuricemia or gout, and it can inhibit the metabolism of azathioprine, which is marketed as Imuran. This could result in bone marrow suppression. In general, this combination of medications should be avoided. It is considered to be very, very dangerous indeed. So watch out. Now, allopurinol is another xanthine oxidase inhibitor which can cause this same drug interaction. So avoid co-administering either azathioprine with febuxostat or allopurinol with azathioprine, because there would be serious bone marrow suppression. I would like to add that ethambutol is an anti-tubercular agent which is well known to increase the levels of uric acid, but it doesn't interact with febuxostat, so there would be no bone marrow suppression. Now, while carbamazepine and methotrexate both have the ability to affect the bone marrow, there is no increased risk with the co-administration of febuxostat. Now, I'd like to add that allopurinol is commonly used in patients at a high risk of tumor lysis syndrome alongside aggressive IV fluids. That's just a by the way. Let's move to the next slide. The question reads, Mrs. JRM, a 35-year-old female patient, presents to your clinic, to your rheumatology clinic to be specific. This patient suffers from moderate to severe rheumatoid arthritis, abbreviated as RA. She currently takes methotrexate once a week, and she informs your clinical team that she needs something else for additional control over joint pain, which is becoming unbearable. She is beginning to develop ulnar deviation of the wrist and the hands. The clinical team considers her a candidate for golimumab, which is marketed as Simponi. They consider using golimumab therapy. So my question to you is, which of the assessments or workups listed below is the most important to do prior to the initiation of golimumab therapy in this particular patient? Would it be the tuberculin skin test? Would it be the G6PD levels? Would it be serum creatinine? Or would it be a CRP alongside the ESR? I'll give you 10 seconds to choose the correct answer. So the tuberculin skin test would be the correct answer. Now, like all TNF antagonists, golimumab or Simponi use requires the patient to be assessed for the presence of active or latent tuberculosis. Failure to evaluate for the presence of TB can result in reactivation of latent TB or even new infections. So you have to be very, very careful. Now, any patients receiving TNF antagonists should be evaluated for the presence of active or latent TB prior to initiation of treatment, regardless of the indication. TNF antagonists can also worsen heart failure. They can increase the risk of lymphoma and other malignancies and even systemic fungal infections due to their immunosuppressive properties. So be very careful when initiating therapy with them. Let's move to the next question, please. And it reads, in which of the clinical scenarios listed below is the use of risedronate, marketed as Actonel or Atelvia, in postmenopausal women contraindicated? Is it in cases where there is a history of chronic pancreatitis? Is it in the cases where the creatinine clearance is below 60 ml per minute mark? Or is it in those cases where there is inability to sit upright or stand for at least half an hour? Or is it in the presence of an esophageal stricture or an achalasia? I'll give you 10 seconds to choose the correct answer. Both answers C and D are correct. Now, risedronate, marketed as Actonel or Atelvia, is a biphosphonate, and it's used in the treatment of osteoporosis. Contraindications to its use include the following: creatinine clearance of below 30, not below 60, so that makes B wrong. Below 30 ml per minute. It also includes the inability to sit upright or stand for at least 30 minutes. It also includes the presence of an esophageal stricture or achalasia. I would like to add that risedronate is associated with esophageal damage in conditions or situations where there is delay in esophageal emptying. Now, Atelvia is a delayed release formulation of risedronate, and it's always important to rule out and to treat any secondary causes of osteoporosis before using bisphosphonates because of their risks. Remember, they are very corrosive. If they are regurgitated, they tend to corrode the esophagus. That's why it's recommended they be taken when the patient is able to sit upright so that it doesn't regurgitate back and corrode the esophagus. And we also advise to take them first thing in the morning on an empty stomach for optimal absorption. shown. That's just a by the way. Let's move to the next question, please. And it reads, Mrs. MHM, a 67-year-old postmenopausal female patient, presents to your hospital. Your clinical team does a bone densitometry. After the DEXA scan, her T-score at the femoral neck is minus 2.7. So my question is, basing on Mrs. MHM's T-score, what would be the clinical team's diagnosis? Would they diagnose osteopenia, osteoporosis, normal bone density, or the presence of a stress fracture? I'll give you 10 seconds to choose the correct answer. So this is a clear case of osteoporosis, and I'll tell you why. A T-score from a DEXA scan between -1 and -2.5 is suggestive of low bone mineral density, which is abbreviated as BMD, or osteopenia. Now, a T-score from a DEXA scan of -2.5 and lower is suggestive of osteoporosis. And a T-score is generated from a DEXA scan of the bone and is determined by comparison of the bone mineral density of a healthy 30-year-old adult. Now, a T-score compares the patient's BMD to a healthy 30-year-old adult, while the Z-score compares the patient's BMD to someone of similar age, weight, gender, and even ethnicity. That's just a by the way for your information. Let's move to the next question, please. And it reads, which of the medications listed below inhibits uric acid transporter 1 in the proximal renal tubule, causing an increased renal excretion of uric acid, which is used in the management of gout? Is it febuxostat, marketed as Hyaluronic? Is it Biologics, marketed as Steroid? Is it Steroid, marketed as Zurampic? Or is it Biologics, marketed as Elitec? I'll give you 10 seconds to choose the correct answer. So let's see, neural, it is Zurampic. It is. Now, Zurampic is a URAT1 inhibitor, which is used in the management of hyperuricemia and gout. It is only used after other agents have proved inadequate or insufficient when it comes to efficacy. Now, the others, such as Biologics or Crysvita, is a urate oxidase, an enzyme that is used in the management of gout to lower uric acid levels and to make it more water soluble for elimination by urination. Now, febuxostat, which is Hyaluronic, is a xanthine oxidase inhibitor used for the treatment of hyperuricemia or gout. Now, Biologics or Elitec is also a urate oxidase, which is an enzyme, but it isn't indicated for gout. Rather, it's used for hyperuricemia associated with malignancy. Remember that, it's very, very, very crucial. So, my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, I would like to remind you to give it a thumbs up and to like it and to share it widely with your peers out there. If you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration. I look forward to interacting with you in part 66 of our Pharmacotherapy MCQ series. Thank you very much.